Thank you, Dr. Mann, for being with us, and please, you can start.
Thank you, Dr. Ahmed Gabala, for your introduction. It's really a pleasure and honor to be with you today. Thank you, Dr. Assayas, and the organizer for this opportunity to be with you. It's an honor to be with you here, and we'll talk about pancreatic cancer, any changes on the treatment and management. I'm gonna share my screen in a second. Okay, great. So the outline for my talk is going to be talking about a little bit of background, risk factor. Then we're going to go over treatment updates stage by stage for pancreatic cancer. We're going to highlight the new adjuvant therapy, and some changes in the palliative therapy. And if we have time, we're going to go over a few future direction on the management of pancreatic cancer. So pancreatic cancer, last year, it was estimated 56,000 new cases to be diagnosed, which account for 3.2% of all cancers. The death was estimated to be 45,000 cases, which is estimated about 7.5% of all deaths related to cancer. If we looked at the bottom of the slide, you see like the new cases and the death lines, they are barely separated, meaning that this is a challenging disease and more need to be done to get these lines separated and save more lives. 5-year survival for pancreatic cancer is around 9% from the data from 2009 to 2015. It's the 11th most common cause for cancer. However, it is the 4th leading cause for cancer-related mortality. It's come after lung, colon, and breast for women and prostate for men. It was expected that by 2030, it will be the 2nd cancer killer. Pancreatic cancer called a silent killer because by the time the symptoms appear, patient already have an advanced stage. Lesion at the head of the pancreas usually present with jaundice, while lesion on the body or head or the body of the pancreas present with pain because it's pushing on the mesenteric plexus and splanchnic plexus, and that's the typical presentation is epigastric pain with some radiation to the back. Lesion in the tail usually present with constitutional symptoms related to the metastatic disease. And it was estimated 5% will present with acute pancreatitis. This risk factor is known to us. Environmental factor, which account for 25%, including smoking and pancreatitis. Metabolic factor account for another 25%, including obesity and diabetes. Genetic with familial pancreatic cancer and hereditary syndromes are known risk factors, in addition to the mucinous pancreatic cyst that include MCN and IPMN. We have some control in the first 2 risk factors. However, we have no control in the genetic and the mucinous pancreatic cyst. As we know, 10 to 20% of pancreatic cancer presented as resectable. On the other hand, 30 to 40% of cases present with local advance unresectable, and the rest and the majority of cases presented with advanced metastatic stages. And we recognize over the last 10 years a new clinical stage called borderline resectable, that for patients who are not resectable now, but can be changed to be resectable once we give them some kind of a treatment, quote unquote, a new adjuvant therapy. The surgical resection is the only potentially curative treatment with survival improvement. However, the improvement is, we're talking about less than 2 years. On the other hand, most patients are diagnosed with unresectable and metastatic stage with a median survival of a year. And you notice here from this diagram that chemotherapy is a corner or a key part of the treatment of pancreatic cancer in all stages. This is a timeline we're showing changes or approval of chemotherapy over the last 20 or more years on the palliative settings. 1996, gemcitabine was the standard of care. Almost 10 years later, erlotinib was approved based on clinical trial with statistical significance. However, clinically, it's not meaningful, and we rarely use it in our practice. 5 years later, FOLFIRINOX was approved in 2010, and 4 years later, Gemabraxane was approved, or nab-paclitaxel. And actually, this is it for the palliative setting. However, the changes on management of pancreatic cancer and the new strategies is actually been evolving for sub-patient population. For example, on the borderline resectable, the new adjuvant setting, there is some improvement in that regard. For this patient population, the treatment option include upfront surgery followed by adjuvant chemoradiation, or induction chemotherapy followed by chemoradiation and then surgery, or induction chemotherapy and followed by surgery. And there's no clear data about which treatment is better than, if the treatment or one route is better than others. ISPAC 5F is actually a trial that presented in ASCO of this year, and it's highlighted some of these questions. In this trial, around 90 patients with borderline resectable pancreatic cancer were randomized to surgery or to chemotherapy with GemCab, basically gemcitabine and capecitabine, versus FOLFIRINOX, or chemotherapy with radiation and with capecitabine as the radiosensitizer. And the dose of radiation is 50.4 gray. Patient will restage and then went for surgery, and this is followed by adjuvant therapy. Some of the finding here that the estimated 12 months survival for patients who had surgery up front was 42%, while for patients who have a new adjuvant therapy found to be 77%. So suggesting that those patients need to be treated with some sort of treatment before they go into surgery. Further analysis, they found that, patients who have GemCab, they have the 12-month estimated survival of 79%, while patients who have FOLFIRINOX have 84%. Compared to the patient who have chemoradiation therapy, they have a 64% of estimated 12-month survival. So you can tell that, there is benefit from giving those patients systemic chemotherapy, which is sound like slightly better than just chemoradiation by itself. Another trial called Pre-O-Panc tried to answer the question where we're comparing upfront surgery compared to chemoradiation with gemcitabine. This trial, patients will be randomized to upfront surgery and then followed by 6 cycles of adjuvant gemcitabine, compared to patients who have a new adjuvant gemcitabine, followed by gemcitabine with radiation in a sandwich style, followed by gemcitabine, and after that, patient went to surgery, and this is followed by 4 cycles of gem. The prelim data showed that the chemoradiation have a better median survival than radiation, with 17.1 months compared to 13.7 months. However, later the data was matured and published, and they shown that there is no improvement in overall survival for those patients who were treated with chemoradiation with gem compared to patients who went to upfront surgery. However, there's benefit with increase of progression-free survival and time to failure for treatment. What about on the adjuvant setting? Since 1985, we know that adjuvant therapy for pancreatic cancer have a benefit. In this trial, the JET-SIG trial, patients who have observation have the median survival of 10 months, while patients who have chemoradiation therapy with 5FU have a median survival of 21 months. So this is proof of the concept that adjuvant therapy increased survival for pancreatic cancer patients. ISPAC-1 trial was published in 2004, where it showed that patients who have chemotherapy with 5FU have an overall or median overall survival of 20 months compared to the observation arm, which have a 15 months. This trial was followed by ISPAC-4 trial, in this trial, they tried to compare gemcitabine as a monotherapy compared to gemcitabine with capecitabine for 6 cycles each. And they found that for gemcitabine by itself, the median overall survival is 25 months compared to the 28 months with gemcitabine and capecitabine. And this has been the standard of care till we have the new trial, the Prodigy 24, that was presented in 2018 in ASCO. In this trial, patients who have R0 or R1 or resected pancreatic cancer were randomized to modified FOLFIRINOX compared to gemcitabine monotherapy. Patients were treated with 6 months of either treatment, and a CT scan was done every 3 months. Interestingly, in this trial, the median overall survival for modified FOLFIRINOX in the adjuvant setting was found to be around 55 months compared to 35 months of gemcitabine. And that was actually a practice changing, and all patients who can tolerate FOLFIRINOX have been receiving FOLFIRINOX since then. What about on the palliative setting? As I mentioned earlier, FOLFIRINOX or gemcitabine with nab-paclitaxel have been the standard of care after the 2010 and 2014, after the approval of both medication. The median overall survival ranged from 8 to 12 months with a BFS of 6 months. However, for certain population who have germline mutation in BRCA1 or BRCA2, which is around 4 to 7%, those patients are known to have a benefit from platinum-based therapy. And there was like a trial that's been conducted to see if those patients can benefit from targeting PARP pathway in a maintenance fashion. This actually was addressed in phase 3 POLO trial, where patients who have it treated on a palliative setting, who are treated with first-line platinum therapy and have like a stable disease, were randomized to have a placebo or Olipart, which is 300 milligram PID. And the study was conducted to look for progression-free survival as an endpoint, primary endpoint. And interesting enough, patients who receive Olipart have a median progression survival of 7.4 months compared to 3.8 months for the patient who receive a placebo. So this is actually the changes in the management of pancreatic cancer on those sub-patient population. So what about the future direction? As we noticed, there's not much of targeted therapy, there's not much of immunotherapy had been presented earlier. So historically, pancreatic cancer had been known to be a cancer with no clear actionable molecular mutation. It's known also for a dense desmoplastic inner stroma that make it a challenge to treat pancreatic cancer. And it's also believed to be a polyimmunogenic tumor. So each of these characteristics have been an area of interest for research. Some therapy been targeted for tumor cells, others they've been tried to target the stroma, and others, including the immunotherapy system, has been an interest, given that the success of immunotherapy on other cancers. As I presented earlier, targeting tumor cells or actionable mutation have shown that is an eloraltinib, which is approved in the first-line setting, and Olipart that's approved in the maintenance setting. And that's it as far as targeting tumor cells with targeted therapy or tumor cells targeted therapy, basically. Other trials are in the pathway for developing other targets, and this is an area of interest. However, so far, the only thing that's approved and show benefit is PARP pathway targeting with PARP inhibitors. Targeting stroma has been an interest, and there's multiple pathways have been targeted using different antibodies, small molecules. some of these, or actually most of these, has been failed at different stage of their clinical development. The one that's standing out actually and reach phase 3 trial is targeting hyaluronic acid by using a human recombinant hyaluronidase enzyme. The concept of this is that by targeting hyaluronic acid, you decrease interstitial pressure, and that allow this collapsed blood vessel to expand and allowing delivery of more of chemotherapy, and the hope to have a better response to chemotherapy by modulating the stroma. In a HALO 202 trial, this is a phase 2 trial where patient was treated with Gem/Abraxane or Gem/Abraxane plus the big PH2O, which is the hyaluronic acid targeting agent, hyaluronidase enzyme. And the initial data actually showed there is an improvement in the progression-free survival for patients who have high hyaluronic acid in their tumor. So this phase 2 data was encouraging and leading to a phase 3 trial. The HALO 109-301 is a phase 3 trial using the same concept on HALO 202, where patients were randomized, around 500 patients, to receive Gem/Abraxane or Gem/Abraxane with the hyaluronic acid targeting agent. Unfortunately, this was a negative trial where there's no improvement in the median overall survival when we're comparing the two regimens, Gem/Abraxane alone or Gem/Abraxane plus the hyaluronic acid targeting agent. So this reached phase 3, unfortunately, there was a lot of hope around this trial, but it didn't make it. The last part, when I'm trying to keep it short for the 20 minutes of the talk, is targeting immune system. The initial trial that's exploring using checkpoint inhibitors have shown promising data on non-small cell lung cancer, melanoma, and renal cell cancer. If you notice in the same paper, New England Journal of Medicine in the 2012, they highlight that pancreatic cancer was not, there was no objective response on this patient population. So since then, multiple trials have been trying to target immune therapy or using immune therapy to target the immune system or modulating the immune system in pancreatic cancer. So far, there's no success or a practice changing, if you will, trial. However, in the pipeline, there's multiple drugs that try to target the checkpoint inhibitors or using vaccine or using CAR T cells or modulation of the immune system and the microenvironment of the pancreatic cancer tissue. However, so far, there's no strong data to be presented. However, hoping that in the future, we might have some data to present in the immunotherapy in pancreatic cancer. I would like to keep it short and give some time for discussion. With that, I will open the door for question and discussion.
Thank you, Professor Mann, for this interesting presentation, concise, to the point. So I ask the attendees if they have any question, just to send to me. Thank you.
Thank you.
I see Dr. Ahmed Abdelrazak, Professor of Surgery at Ain Shams University. He wants to ask a question. So Dr. Ahmed, please, you can ask the question, please.
He might be muted.
Dr. Ahmed, can you send me the question? Yes, I received a question. You can send me the question, please, Dr. Ahmed and Dr. Muhammad, Dr. Asma. Send me the question and I'll present. Dr. Maan, the first question is from Dr. Ahmed Ali. He's from Zagazig University. He's asking about evaluation after neoadjuvant. What is the best modality to evaluate response after neoadjuvant therapy?
That's a very good question, actually. And evaluation for response after neoadjuvant actually should be on a series of a CT scan with Pancreatic protocol. So we usually base decision not on only one scan after the initial treatment. We read it in a series of scans. So after having 2 months or 3 months of treatment, then reevaluate. We can send another 2 months of treatment. It can be either chemotherapy or chemoradiation. So this is option. The trend that we have in our practice here is we give systemic chemotherapy, we evaluate with a CT scan, then we give another systemic or chemoradiation, and we evaluate for another scan. And by that time, you can have an idea about the tumor biology and if this patient is really a good candidate for surgery or not. In average, 30% will downstage to resectable. And but CT scan, back to your question, is the best way with pancreatic cancer protocol.
So you don't think that PET scan have a big role in pancreatic tumor?
If you're suspecting, a metastasis or you're suspecting a lesion in the liver that you want to address before proceeding with surgery, then a PET scan might be. But if you're looking for resectability apartment to or close to the blood vessels that you look for a resection margin, then a CT scan will give you a better resolution, and the surgeon like to with the pancreatic protocol where they can know their margins if it's going to be positive or negative, or they know their field of resection. But PET scan definitely, if there is a question mark about possible lymph node distant, or then that's above 1 centimeter. Anything below 1 centimeter is hard to detect on PET. If it is above 1 centimeter on CT scan, then PET CT scan will be a good modality to rule in or rule out this mets.
We have a question from one of the hepatobiliary surgeons, Dr. Ahmed Abdelaziz, professor at Ain University. He is asking on the clinical practice, clinical scenarios, we don't see satisfying rate of conversion for borderline tumors. As presented in the presentation, we have a high conversion rate. But in the clinical practice, he is not seeing these rates.
I would agree. It is vary. And actually the data, I have this very good question. I have the same question when I present similar data elsewhere. The question was actually it's practice. Some institutions have a better response than others. It's also depend on the practice of the institution. What is the modality of the neoadjuvant? Is it FOLFIRINOX for 2 months, or it is some other therapy? In average, actually, it's the data that's presented. They say 30%. This is some data presented elsewhere. It might be less because the aggressiveness of this disease and the biology of this disease vary. So I would say even what we think initially it's resectable, some while they are in an adjuvant therapy, neoadjuvant therapy, you find disease progression. So this is not uncommon in pancreatic cancer. And sometimes you end up with seeing a metastasis. So the resectability on those data or this trial, it can be local, or it can be like a new spots in the liver that were not seen, and now it's appear when you repeat CT scan. So it is vary. This is a good question. I would say the biology of the disease and the practice. Are we including only chemotherapy systemic, or are we including systemic plus chemoradiation?
Yes. Another question from Dr. Hussein Meki from Sudan. He's asking about in the palliative setting, What about adding oxaliplatin to gemcitabine? Do you prefer to do this or no?
If I want to use oxaliplatin, I will use it with 5-FU. Even if you look on the third line treatment, the Onivide, which is Nal-Eri, patient they benefit, which is the category 1 data, patient benefit from oxaliplatin plus 5-FU after they failing gem. There is no strong data about using gemcitabine with oxaliplatin. I will not say this is not a good practice, but I would say like we're lacking strong data on that regard. Gem had been in the setting with Abraxane, and we always see oxaliplatin with 5-FU, even in the third line setting with Nal-Eri. My apology, I mean Nal-Eri, this is a different scenario. And in the third setting, if you do including Nal-Eri with 5-FU, you can use Folfox for patient who can't tolerate FOLFIRINOX upfront. For some patient, we use Gemabraxane as a first line because not everybody is fit for FOLFIRINOX. When we try to go for the second line, then I would say like 5-FU with irinotecan or 5-FU oxaliplatin can be another option.
Okay, thank you, sir. I have another question. Actually, it is one question from two different doctors, Dr. Saha from Egypt Air Hospital and Dr. Ahmed from Zakazaki University. They have patients with a strange rare pathology, which is squamous cell carcinoma histology in the pancreas. So they're asking about how we can manage this strange rare histology in the pancreas.
This is an interesting, and actually there is some data about the molecular profiling of pancreatic cancer. We know that pancreatic cancer, the location, there's some data that's been published. The location of the disease matter, but when they look further on this, the location, they found actually the histology and the molecular profiling matter, because the molecular profile might be some squamous features. Those usually are challenged to treat, but those with the squamous feature, including radiation, might be a good strategy and to include in their regimen. Definitely those patients, when we have such weird histology, always good to have molecular profile and look further for actionable mutation. If they have a BDL1, we have patients who had BDL1 staining that is like 20%, 10 to 15 or 20%, and they have some response actually, and they are MSI stable, and they have some response to immunotherapy. So those patients and those histology can be more aggressive than what adenocarcinoma that we used to treat, and these are the adenocarcinoma that's are on the trials. We didn't have much data on the other histology or the squamous, but those they should have molecular profile done to them and further characterize them. But with the squamous, with including the radiation might be beneficial.
If the patient is metastatic, has squamous and metastatic, so radiation will be of minimal rule. So you prefer a specific chemotherapy protocol in this situation?
Cisplatin based will be like a good regimen, given that our knowledge about squamous and cisplatin the regimen. So you're referring to somebody? Are we dealing with cancer of unknown primary? Because we have I published case reports, and actually we had some not typical metastasis to the pancreas that came from elsewhere. So I would say, like, if you see this, it might want to consider cancer of unknown primary, and you want to do a little bit more of evaluation.
Okay. We have another question from Professor Maya Zedin from Ain Shams University. If we have patient with poor performance status, ECOG 3, or it's better to not to treat, or if you are going to treat, which protocol you will use?
You said performance status of 3?
Yes.
This is a good question, and actually there is data been shown that is performance status of pancreatic cancer influence the outcome, and selection of a treatment really can either improve or basically worsen the outcome. So with those patients with performance status of a 3, I would say monotherapy with gem might be a safe way to go. And if we are looking only for a palliative, some patient, if pain has been an issue for them with a local, we know pancreatic cancer with spleen plexus being affected, pain is a major issue there. Sometimes we include upfront radiation with Xeloda to have some palliative control, and if it is a local advance, gemcitabine monotherapy is appropriate. That's, I would say, like the safest way to go with those with BS3.
Okay. I think we finished with all the questions sent to us. Thank you, Professor Maan, for this nice meeting and this nice discussion. And I hope we have future collaboration, inshallah, and we have you again in our educational sessions, inshallah.
Thank you, Dr. Ahmed, and thank you again for having me. It was a pleasure, and I enjoyed the discussion with the group. Best of luck.
Thank you, sir.
Take care. Have a good day.
Thank you all the attendees, and you are welcome to join us, inshallah, in the future meetings.
Looking
Thank you, and salam alaikum.
Wa alaikum assalam.
Salam alaikum.